Good afternoon. Sorry for being a few minutes late. We were having a few glitches, but we're here now. And I want to welcome everyone to our March Public Health Practice Grand Rounds. My name is Janie Gordon, and I'm with the Mid-Atlantic Public Health Training Center. And we have these Grand Rounds monthly. Today's topic is from mental health and substance abuse to behavioral health services, opportunities and challenges with the Affordable Care Act. I have a few announcements before we get started. For people who are watching online, please check out our archive grand rounds and other online trainings, as well as our face-to-face trainings. Also, our grand rounds are usually the third Wednesday of each month, but next month, April, we will be having our 5th annual Sexual and Reproductive Health webinar on April 2nd. And the topic will be the intersection of clinical and public health practice, STI management in the HIV-infected person. Again, for people watching online, you can email a question anytime during the presentation to today's presenters by simply clicking on the link on your screen, or you can send your email to maphtc@jhsph.edu. With that, we're ready for our presentation on From Mental Health and Substance Abuse to Behavioral Health Services, Opportunities and Challenges with the Affordable Care Act. I'd like to introduce today's speakers. First, and for people who are in the audience wondering where the first speaker is, we have, our first speaker is participating via phone. So I haven't lost my mind and you haven't either. Our first speaker is Ron Manderscheid, PhD, and he serves as the Executive Director of the National Association of County Behavioral Health and Developmental Disability Directors. The association represents county and local authorities in Washington and provides a national program of technical assistance and support. Concurrently, he is adjunct professor at the Department of Mental Health, Bloomberg School of Public Health, Johns Hopkins University, and immediate past president of ACMHA, the College for Behavioral Health Leadership. Dr. Manderscheid serves on the boards of the Employee Assistant Research Foundation, the Danya Institute, the Frameworks Institute, the Council on Quality and Leadership, the International Credentialing and Reciprocity Consortium, and the National Research Institute. He also serves as the co-chair of the Coalition for Whole Health. Previously, he served as Director of Mental Health and Substance Use Programs at the Global Health Sector of SRA International, and in several federal leadership roles in the U.S. Department of Health and Human Services. Throughout his career, he has emphasized and promoted peer and family concerns. During the Clinton administration, the Clinton National Healthcare Reform debate, Dr. Manderscheid served as Senior Policy Advisor on National Healthcare Reform in the Office of the Assistant Secretary for Health at HHS. At that time, Dr. Manderscheid was also a member of the Mental Health and Substance Abuse Work Group of the President's Task Force on Healthcare Reform. He has continued this work in support of the implementation of the Affordable Care Act of 2010. Recently, he co-edited a new text, Outcome Measurement in the Human Services, Cross-Cutting Issues and Methods in the Era of Health Reform, and contributed to a new text, Public Mental Health. Previously, he served as principal editor for 8 editions of Mental Health United States. He's also authored numerous scientific and professional publications on services to persons with mental illnesses. Each month, he prepares a commentary, the Manderscheid Report for Behavioral Health Care. Our second speaker, who is here in the audience, Philip Leaf, PhD, is a professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health. He also has joint appointments in the Department of Health Policy and Management and the Schools of Medicine, Nursing, Education, and Arts and Sciences. Dr. Leaf is director of the Johns Hopkins Center for the Prevention of Youth Violence and the Johns Hopkins Adolescent Health Center, both funded by the Centers for Disease Control and Prevention. Co-director of the Center for Prevention and Early Intervention, funded by the National Institute of Mental Health and the National Institute on Drug Abuse and Addiction, and Senior Associate Director of the Johns Hopkins Urban Health Institute. Since 1995, he has served as a mayoral appointee to the Family League of Baltimore City, Baltimore City's local management board. He's been involved in a large-scale community epidemiologic surveys of adults, children, and adolescents. He was the principal investigator for the state's first system of care grant from SAMHSA, the East Baltimore Mental Health Partnership. He has conducted several school-based randomized trials of prevention and early interventions involving multiple school systems, a national survey of internet use, exposure to violence, and he has been involved in evaluations of home visiting programs in Hawaii, Alaska, and Maryland. Dr. Leaf twice served as the chair of the mental health section of the American Public Health Association and serves on numerous city and state work groups. He's created a homeless shelter for substance abusers and a trauma response team, the Baltimore Child Development Community Policing Program, that responds 24/7 to youth who have been victims of shootings and to youth-related murders. Dr. Leaf is a founding member of the Baltimore Interfaith Coalition and a recipient of the university's Martin Luther King Jr. Award for Community Service and the Central Maryland's Ecumenical Council's August Sheehan Interfaith Award for Public Service. And I have to say, these are longer introductions than usual, and they've both been cut because both of our presenters really have done a large volume of wonderful work in this area. So Dr. Leaf is with us live, and Dr. Mandershine, again, is participating via telephone. And they will be moving back and forth in the presentation, which they've worked on collaboratively. So Dr. Leaf, thank you.
Okay, excellent. Okay, thank you, and thank you, Janie, for the wonderful introduction. So let me make a few introductory comments. I guess the first comment I want to make is that going forward here in the Affordable Care Act, it would be very, very important to build a much stronger relationship between public health and behavioral health than has existed in the past. And a good way to encapsulate that idea would be that under the era of the Affordable Care Act, there can be no good public health without a linkage to behavioral health, and vice versa, there can be no good behavioral health without a linkage to public health. And I think there are really three major things Phil and I want to leave you with today about the Affordable Care Act. One is there's a huge amount of work to be done in insurance enrollment and in improving health care benefits. Secondly, there's a huge amount of work to be done in building health delivery systems that are health homes and medical care homes. And thirdly, there's a huge and wonderful amount of work to be done in promoting prevention and positive mental health. And all three of these areas will involve epidemiology and public health, I think, in a way that we've never seen before. Okay, Phil, go ahead here. Let me say also a word about social justice. So this is not just a technical presentation. This is also a presentation about how the Affordable Care Act addresses issues in social justice. So I think the premise we want to make here is that every American ought to have the right to have good health, number one. Second premise, we value all people equally. And then from those two things, we would draw the conclusion you can do nothing other than promote the Affordable Care Act or a suitable alternative if you're going to achieve those health goals for the United States. Okay, go ahead. So, the headlines of the Affordable Care Act. The The Affordable Care Act helps us move toward universal insurance coverage and parity of mental health and substance use health insurance benefits with medical and surgical benefits. There no longer are any pre-existing condition exclusions in health insurance. It's absolutely huge for behavioral health care. The Affordable Care Act fosters medical and health homes. It's really the first time in my lifetime that we have really focused on prevention and health promotion within health insurance benefits. And finally, it actually will bring to the table a lot of work we have done in behavioral health on promoting recovery-oriented systems and actually moving into the era where we are developing the capacity to promote resiliency in people. Now, some of the implications I put on the bottom here, that words you'll see in the Affordable Care Act: person-centered care, where the person is the true north of care; whole person care that puts the head back on the body; shared decision-making between providers and service recipients, have all come of age in the Affordable Care Act, and all three are focal and central in behavioral health care. Go ahead. I want to show you this model. Until about 30 years ago, we believed that illness and health were two ends of the same dimension. We then absolutely had the insight that that wasn't true, that they really are very separate dimensions. And you see that portrayed here in this little overhead. Go ahead. Here you see the same concept portrayed in a delivery system model. Same vertical dimension, which is wellness, same horizontal dimension, which is illness. And our goal in the public sector is to start in the lower right-hand quadrant, where we have people who have high morbidity and mortality. In fact, in behavioral health, in the public sector, public mental health clients die 25 years earlier than other people. And if I have a person who has comorbidity between serious mental illness and substance use problems, that number can rise as high as 42 years. So we have people who have very high morbidity and mortality, and really, if you talk to them, they would say, we have little hope. We have little hope, basically. So if you move in a traditional illness care model, you would then move to the lower left-hand quadrant, and you would be doing traditional biopsychosocial interventions. What the wellness dimension allows you to do is add other features to this. It allows you to add self-help. It allows you to add social support. It allows you to intervene and engage in changes in unhealthy lifestyles. It really brings a very important personal dimension to care. And I would argue that we need to be doing both of these things. We need to be moving in the horizontal dimension, and we need to be moving in the vertical dimension if we're going to end up in the upper left-hand quadrant where we achieve recovery, meaning I have a positive life in the community, I have permanent housing, I have a job, and health. I believe I am a healthy person. Okay, Phil, go ahead. So what are some of the implications of that model for the Affordable Care Act? Obviously, provision of primary care is essential. Provision of behavioral health care is essential. And thirdly, facilitation of wellness and recovery approaches is essential. And the way the Affordable Care Act will help bring this about is through care integration, and care integration that creates medical care, primary health homes, and behavioral health homes. Go ahead. Now I'm going to quickly go over the 5 domains of reform in the Affordable Care Act. And each domain, I'll give a little definition of the domain, but I'm also going to talk about some actions that virtually everyone participating in this webinar today needs to engage in. Okay? The 5 domains are insurance reform, coverage reform, quality reform, payment reform, and IT reform. Okay, go ahead. So, on insurance reform, The Affordable Care Act is designed to provide personal health insurance to about 39 million adults. And you'll say immediately, well, I always thought it was 50 million. Yes, it is 50 million, but the other 11 million people are not covered by the Affordable Care Act because they are not American citizens. Of the 39 million, based on epidemiological work done in the middle 2000s, we believe that about 11 million of those 39 million people are people who already have a pre-existing mental health or substance use condition, which would give us a prevalence in that population of about 30%. Okay, go ahead. We're going to achieve this insurance reform through two mechanisms. We don't really have time to go into this in great depth today. One is through the state health insurance marketplaces, which are up and operating in all 50 states and D.C. right now, where we would hope to eventually cover about 20 million people, and through the state Medicaid expansions, where we would intend to cover about 19 million people. The very important point here, and I need to make this even though it's not on the overhead, the state health insurance marketplaces will close at the end of March. They'll close on March 31. They will not reopen again until November 15th of 2014. Hence, if you know of people who should be enrolling in the marketplace, they have only a very short time. We're literally within 2 weeks of that right now. The Medicaid expansion enrollments will continue throughout the year, but the marketplace enrollments will not. Another critical feature here, both the marketplaces and their insurance packages and the Medicaid expansions are driven by an essential health benefit. For our purpose here in behavioral health, there are three features of that benefit. Mental health and substance use benefits, which must be at parity with medical and surgical benefits. Secondly, a pharmacy benefit, which is very important to behavioral health care. And thirdly, a new prevention and promotion benefit, which, as I said before, has always been exceptionally weak in health insurance previously. Now it's there, and it will be brought up to speed as we go forward in time, and as the U.S. Preventive Services Task Force develops evidence-based practices which will be brought online. Okay, please go ahead. So now the two actions here in the insurance area. Insurance enrollment is our responsibility. So my challenge to virtually everyone here on this webinar, go out and help at least one person enroll in health insurance before March 31st, whether it be a person who can enroll in the Medicaid expansion or a person who can enroll in a qualified health plan as part of the state health insurance marketplace. The second point, enrolling persons with mental health and substance use conditions is our responsibility based on the experience of Massachusetts that's had universal coverage for 8 years now. About 4.5% of adults in Massachusetts are still not enrolled. 3.5% of that 4.5% are people with behavioral health conditions who are notoriously the most difficult people to enroll in health insurance. Okay, please go ahead. Okay, now Reform 2, which is coverage reform. The Affordable Care Act eliminates pre-existing condition clauses in all health insurance, and that became effective for the entire population on January 1st of this year. It eliminates annual and lifetime limits on health insurance coverage, and it extends family insurance to age 26. The very important point for us here in behavioral health care, everyone with a mental or substance use condition has a pre-existing condition. We all know of people who have been redlined from insurance in years past because they had these various conditions. That is now against the law. That can no longer be done. Please go ahead. I guess the only other thing I would add from this over, look at the bottom here, prevention and promotion. There are no longer any co-pays or deductibles for various preventive interventions. For example, if you have an annual physical in your health insurance, it can no longer have a co-pay. In the behavioral health area, SBIRT, screening, brief intervention, referral for treatment for substance use conditions, is now included in the qualified health plans, and in the Medicaid expansion, it can no longer have a copay or deductible. And as I said before, additional health promotion and disease prevention interventions will be added as we go forward in time. Okay, please go ahead. So the two actions here, it's very important to explain these coverage changes to people who may not understand them. I go out and talk about the Affordable Care Act all the time, and I'm always amazed how little people in the community know about the Affordable Care Act. So when you get together with your friends on Friday night or Saturday night, ask them about the Affordable Care Act and what they know about it, whether they know these coverage changes have actually taken place. And then secondly, I would say as well, it's very important if we're going to make parity work. Parity essentially means that mental health and substance use benefits and primary care and surgical benefits cannot vary in a health insurance package. And secondly, the management of those benefits cannot vary. That's a huge, huge change for behavioral health care, but we are going to need to monitor that in every single state to help assure that every single state health insurance commissioner is paying attention to this and that these parity provisions are being carried out in the qualified health plans and in the Medicaid expansion where that is occurring. Okay, go ahead. Okay, third area, which is quality reform. The Affordable Care Act provides for the creation of integrated health homes, which offer prevention and promotion as well as care. And these health homes will ultimately include a whole range of services: mental health services, substance use services, primary care services, in some places dental services, and in even some other places public health services. In Oregon, the community care organizations in Oregon actually include public health. Wonderful linkage there. Second bullet here, mental health and substance use care providers will need to become part of accountable care organizations. And accountable care organizations are the entities that will operate health homes. So my question to virtually every one of you participating in the webinar today, do you know of work going on in your own community to create accountable care organizations that are going to operate health homes? Okay, go ahead. So what are the key features of this? Health homes can be created through modifications to Medicaid and Medicare. The one I want to point out here particularly is the Medicaid State Plan Amendment, which is covered in Section 2703 of the Affordable Care Act. The Medicaid State Plan Amendment to create health homes permits 90% federal money to create the health home for the first 2 years of the amendment. A state can have multiple amendments. You can have an amendment for adults with serious mental illness. You can have an amendment for adults with substance use disorder. You can have an amendment for adults with diabetes and heart disease, and on and on and on. A huge opportunity for states to make progress in implementing health homes. The accountable care organizations that will operate these health homes will be generally operated out of the healthcare sector, but can also be operated by behavioral health entities. For example, I expect that in Maryland, as an example here, the federally qualified health centers in Maryland will be creating health homes, and they've been given special resources to do this. But I would also expect in Maryland that behavioral health entities, community mental health centers, would also be creating health homes, and counties in Maryland would also be creating health homes. Very important to point out here, the word accountable is not just the word added here. These accountable care organizations actually will ultimately be accountable for the federal money they spend. Hence, quality measures that will drive quality improvements in those health homes are going to be very important. That's a whole subject unto itself. I hope there's some questions in that area. Okay, go ahead. So the two actions in this area, It is our responsibility to foster the development of health homes and accountable care organizations. So when you go out and look at what's going on in your community, if there's nothing going on, stimulate something in your own community. It's also our responsibility to investigate related services such as social wraparound and public health services. I believe, and I know they're generally believed in the behavioral health field, the health benefits of the Affordable Care Act cannot really be fully successful for public sector clients unless those clients also have access to necessary social wraparound services. These would include things such as job supports, housing supports, and social supports. You know, if you have pneumonia and I treat your pneumonia, but you live out under a bridge, I can't expect that my health care is going to be very successful. And then similarly, with the addition of public health services, many public health initiatives have huge implications on health status, smoking, obesity, these types of things, and it's absolutely essential they be part of this work. Okay, go ahead. Okay, fourth area here is reform, payment reform, and the basic idea behind payment reform is to reward strategic service delivery rather than more and more service delivery. The current system, the fee-for-service system, rewards providers to give more and more service. And you make money by giving more and more service. You don't make money by giving services strategically. Okay, go ahead. The Affordable Care Act will implement performance-adjusted case rates, which is an amount paid at the beginning of a year to cover the care for a person for a whole year, or capitation rates, the amount paid at the beginning of a year per person to assume responsibility for the health care of a population for a year. And the goal here in the Center for Medicaid and Medicare Service that within 10 years, no federal money is spent that's not in the format of a case rate or a capitation rate. So this is very, very important. Under these systems, as we move ahead here, mental health and substance use care providers will need to self-manage insurance benefits. And what will happen to you if you don't self-manage, you will go defunct financially. And that's why I mean strategic service delivery rather than more and more service delivery. Go ahead. So it is our responsibility to understand case and capitation rates and how they will apply to emerging health homes. And I think a huge part of going forward here in public health training at Hopkins and elsewhere is to begin talking about these new systems. Secondly, it's our responsibility to develop internal service management approaches that promote strategic care. Be a huge, huge transition for behavioral health care from where it is right now. Okay, please go ahead. And finally, Reform 5. The Affordable Care Act reforms information technology. And the reforms in the Affordable Care Act already assume that providers are using electronic medical records. Go ahead. The ACA provides financial incentives for use of electronic medical records for federal reporting. So, as an accountable care organization, reports its performance measures to the federal government. If it's using electronic medical records to do that, it will get a positive bump in its Medicaid payment. Secondly, the Affordable Care Act provides financial incentives for use of electronic records for training. So at Hopkins, this would be a very important thing. If Hopkins is actually using electronic medical records for training, there are positive federal incentives for doing that. Go ahead. So the two actions in this area, it is our responsibility to implement electronic medical records, and secondly, it's our responsibility to implement personal health records. A personal health record is a record that belongs to a consumer that's driven by information in the electronic medical record, but one in which the consumer then can take progressive responsibility for management of that person's own health. And It's very important we not just develop electronic medical records, but we also make this opportunity for personal health records available to consumers. Okay, go ahead. Just about ready to wrap up here. So if we do these things that I've been talking about here, what would I expect? I would expect longevity of behavioral health clients to improve. I would expect that 25 years of lost life to be decreased. I would expect recovery to improve community tenure. And I would expect community tenure to improve community participation, where a person actually has permanent housing, they have a permanent job in the community, and they have a permanent social support network. We'd also expect the implementation of prevention and promotion protocols to improve personal and population health over the longer run. Hence the absolute importance of having public health involved. Okay, go ahead. Final overhead. So community life under the ACA, what would we expect? In community life, we would expect that there would be greater attention to the social and physical determinants of health, things such as poverty, level of education, health education, discrimination, poor physical environment, these types of things. We would expect more community participation in addressing local health issues, less stigma around behavioral health conditions in the community, and greater recognition that all health and health care is local. And so I'm going to stop at this point and turn it back over to Phil. Thank you very much.
So we're going to do a little bit of some combination of Groundhog Day and Christmas past, present, and future. As Ron pointed out, the act itself created legislation that allowed for correcting a large number of insurance policies, both the fact that people aren't insured, but also there were pre-existing conditions. And as Ron said, most persons with mental disorders, by definition, have a pre-existing condition, which meant if they were uninsured, it was often very difficult, even if they got a job, to get insurance because they would be excluded. There's also an attempt and recognition that, to some extent, our health care, in particular our behavioral health care services, have evolved and expanded to be consistent with the funding mechanisms, which meant if there was a fee for service or money was just through the block grants for alcohol services or substance abuse services, that's primarily what the patients, that the physicians and other folks prioritized. And as a result, we have a really siloed system. And it's often siloed by funding, not simply by primary care or mental health. So there's legislation that really focuses on how to improve quality, including evidence-based practices using electronic measures and monitoring, as well as an attempt to reduce the overall cost of health care, because by providing more appropriate health care, and particularly the prevention services, the assumption is that the money would go further. And then finally, as Ron said, prevention, both general prevention, but also around substance use, mental health issues, alcohol, as well as increased well-being. This whole idea that there needs to be two dimensions. There may be people who have illnesses who they're not cured of. They are going to continue to have that illness for their life, but that doesn't mean that they can't have a high quality of life. It doesn't mean that they can't be a very important contributor to our local communities. And so increasingly focusing both on those dimensions, making sure that if there's things that need to be done, that people can go into recovery, but the recovery also means high functioning. So there's a code of tribal wisdom, and also from my friends in Philadelphia, that says when you discover you're riding a dead horse, the best strategy is dismount. Well, it's clear that there's an enormous consensus in the U.S. that our health care, and particularly our behavioral health care, was not working all that well. Unfortunately, a lot of states and a lot of individuals are continuing to say, well, we shouldn't have an Affordable Care Act. Also, there's nothing else we should have in replace of it. So it's not clear that we always dismount, as well as Ron was starting to allude to, because we have another funding stream doesn't mean that we're really integrating our services and using evidence-based practices. So unfortunately, those of us in public health, we sort of love our dead horses. This is what we were trained to do. This is what this is what our friends are doing. And one thing, this is sort of the way we've always done it. And there's a lot of evidence from research that if you survey clinicians, they always report that their patients do well. Now, they might recognize that other patients aren't doing so well, that the general field is not doing so well, but everybody thinks that they're doing really well. In Maryland, I suspect other places have committees. We send out for crabs. Other people probably have their own local specialties. A lot of studying. One of the things about increasing funding, now there are some mechanisms, and Ron also alluded to this, particularly through some of the qualified federal health centers. There's incentives for them to get involved in behavioral health. There's incentives for them to get involved in school-based programs. There's also were incentives for expanding the Medicaid coverage with 90% being picked up. For prevention services, IT. So there's a lot of incentives in there. So potentially, at least initially, there may be some initial funding. But one of the things, and I'll get to this later on, if we have a lot of things that aren't working, just linking them together, making them, co-locating them, or providing good referrals to them, if they're not working, is equivalent to sort of linking these three dead horses and assuming the cart's going to go farther. We have seminars, and I guess the dean's in Japan, so hopefully he's not watching. The other thing is we focus a lot on standards, but we increase standards, but the actual quality of the services being delivered to the average person doesn't necessarily increase. And so we need to really, as Ron was saying, improve the outcomes in the populations. And not simply focusing on whether a small number of clinicians are better trained or we have higher standards for doing certain services. And the other issue about the increasing of standards is in behavioral health, there are a lot of very effective consumer-driven programs. People in the audience and watching are probably familiar with the recovery movement for alcohol and drugs, which are not professionally driven. There's also a substantial recovery program and peer-run services for persons with mental disorders. That the competencies there is being someone who's been affected by the illness, not necessarily someone with an academic credential. And there's a lot of concern in the recovery communities that part of what the Affordable Care Act may be doing is leaving them out. Ron mentioned the assumption is there's electronic medical records. By definition, the recovery movements don't even have sign-ins for who's coming to those programs. It's, it's first name when you go there. It's not meant to be a medical service. And so to the extent that there's difficulties integrating these type of approaches in the Affordable Care Act different programs is something that a lot of consumers are very concerned about because they personally are finding value for participating in these programs. And sometimes we sort of, as has been exhibited in a number of states, people got promoted to run some of these, and some of them have now moved on to some other job or some non-job because they weren't very successful. Visiting each other. Again, we're all in the same boat. Everybody in the U.S. is sort of starting, even Massachusetts is at an relatively early stage. And as Ron mentioned, for persons with behavioral health problems, particularly substance abuse and alcohol, there hasn't been the same level of inclusion even in the covered lives. So we need to not just make a change our collaborations and sort of say this horse isn't dead. We really need to be moving forward and figuring out how we're going to do this. Luckily, there's probably lots of job source academics, but I think one of the closing things that Ron and I are going to be dealing, and Ron kept pointing out the actions people need to take, is that there isn't a lot of experts in this. There aren't places that got early drops on this. There's some good early lessons from Oregon that I'll talk about. There's some lessons from Massachusetts. But again, these are not sort of national lessons, and they weren't the full implementation of what the Affordable Care Act. So those of you who are familiar with Field of Dreams, if you build it, he will come. It's not clear that we have this legislation, and the legislation itself was a compromise, but it's not clear that the legislation itself is going to be putting in effective programs of services for persons with behavioral health problems or persons at risk for behavioral health problems just because they have the legislation. And Ron, in each of his descriptions of what a component of the program was, had action statements. And if those actions aren't taken, then the field will never get built. So yes, the Affordable Care Act went into full effect January 1st. Some of the provisions, such as keeping children on parents' health insurance, kicked in earlier on. But it's not clear, both in terms of the number of covered lives that are still not covered, including the persons who are not legal immigrants who weren't intended to be covered by this law, but there's still large numbers of people who haven't been included, and that varies enormously from state to state. It's also not clear that all the states have gotten behind implementing the full Affordable Care Act. And as Ron talked about, we had 20, 30 years of primarily segregating behavioral health services and physical health services, funding streams differently, run out of different parts of the state. And so simply because we have some legislation and we're having more integration at the federal level and at the state level of these agencies, it's not clear that the Affordable Care Act today resembles very much of what it hopefully will look like 3 or 4 years from now. So we have, as of a couple of weeks ago, 4.2 million people have selected plans in either the state or federal exchanges. A lot of them were in the Medicaid programs, but we had a large number of people who were not insured. And even if we exclude the illegal immigrants, we still have a large number of people in the United States who aren't insured. And now we're sort of eliminating our focus from the uninsured because we have the Affordable Care Act. We have plans that we're working on. And so now, unfortunately, local communities, advocates, clinicians are going to have to sort of be living in two worlds at the same time. How they function under the Affordable Care Act, but there still will be a lot of people without health insurance in their local communities. So this probably doesn't look too familiar to many of you. This actually is Bryce Hospital in Alabama. It's probably, I don't know, early 50s. And this was our former system of care. It was self-contained. You can see in the back there as a farm, grew most of its own food, had very low-cost employees for managing most of those food, had all kinds of, this at one time was the largest continuous building in the country before the Pentagon was built. So we had these very large systems of care. We moved then to the 70s and decided we were going to do something else. We had a lot of good legislation for community-based services, but the reality was the services weren't in the community. And although we dismantled one system of care, we still don't have the full system of care 30, 40 years later. We do have some examples and some early components of the Affordable Care Act, the Parity being one, and Ron alluded to the fact that you had to have similar coverage for behavioral health and physical health. So there was some parity legislation that went in earlier. It actually focused not on getting people who were uninsured insurance, but if you had insurance, there had to be parity between your general health care coverage and your mental health coverages and behavioral health coverages. It only applied for employers who had relatively, they're not huge companies, but certainly not 2 or 3 person companies. There wasn't, it had classes of benefits. The scope of services were supposed to be largely analogous. And so we're now getting some studies that have looked at the impact of those. What were the characteristics of service care before the parity legislation went in? What were the characteristics of those people being served after the parity legislation went in? And we would hope that these are all people who had insurance to begin with. We're simply saying that their mental health services had to be covered in the same way that their physical health services had to be covered. That there probably were a lot of people who were not getting behavioral health, mental health, substance abuse services. We'd want to see more services. And so there's a large study from 5 commercial plans in Oregon that looked between 2005, 2008 is getting the baseline data. Oregon was one of the early adopters of parity legislation, so they actually had their legislation in 2007. So they were able to look at comparing, here's the programs before, here's the programs afterwards. It's the same coverage programs. But they found, although there was an increase in the coverage, there was no significant increase in drug abuse treatment and no differences in overall services. So what we'd expect if we were making services available to people formerly who either had to pay totally out of pocket because their health care didn't cover it, or had to pay a larger amount for a behavioral health service than for a physical health services, that they would be getting more services, and that didn't happen. And indeed, in a recent review by McCarty, he was unable to identify any studies that found increased use of mental health or substance abuse services following the implementation of parity legislation. Now, they were able to find decreases in out-of-pocket costs. So again, there was some coverage there that people didn't have to be paying for these things themselves. But what seemed to have happened was, therefore, an overall reduction of services, whereas there's an increase, so the overall cost sort of stayed the same. It didn't come out of the pocket, it came out of the insurance package, but there weren't more problems, more services provided. And I think, again, this is thinking about the future and using these canaries in the mine shaft to at least be concerned, to be looking at these things as we get coverage, what's going on. Because as Ron talked about, the uninsured have much higher percentages of persons with mental health problems, alcohol, and substance abuse. So if we're getting more of those now into coverage to begin with, we should even find a larger increase. So another issue that Ron alluded to was, improving quality and reducing costs, that we want to improve the individual experiences of care, both in terms of their outcomes, but also their access. There are components of this that talk about using evidence-based services, trying to get providers to use services that have been shown to be working. The health homes, which combine the mental health, substance abuse, behavioral health services with health services, because again, that's been one of the challenges that persons with serious chronic mental health or substance abuse problems have been in the past. They had to literally live in 2 different service delivery systems. So integrating those things, particularly with primary care, so there hopefully can be earlier detection of these problems and prevention. So that over time, we are, by earlier detecting these problems, we're reducing the morbidity and the disabilities. By having better and more effective prevention, we're actually reducing the number of the people that have these illnesses to begin with. And the Maryland Health Home, one of the ways of trying to do that, each of the states are doing some of this slightly differently, but Maryland, we are integrating the somatic and behavioral services. We're targeting those populations that have behavioral needs and have high risk for chronic health problems. And so the state is, again, actively trying to figure out how do we get the best services for persons with persistent mental health, behavioral health problems, with persistent physical health problems. How do we provide those services efficiently and effectively in a context that the consumers also find accessible and preferable. So again, it's not necessarily a service, it's really a community-based approach, not a residential program. The name home thinks, well, it's people live. It's really creating these service communities and support communities that will be multi-sectoral, multi-institution, that will be person-centered, that'll enhance the person's participation to manage. And this again gets to the issue of how much are we able to then involve the recovery programs? How much are we able to involve the consumer-driven programs? Because those programs have not traditionally been part of our healthcare services. Yes, some of our larger services might have a room that they let the people come into, for a weekly meeting or even a daily meeting. There are, in Baltimore City, any day, 20, 30 of these meetings going on every single day of the week, and literally 24 hours a day. This is not a way that our health system has traditionally dealt with behavioral health problems, and so we have sort of linking these conceptual things together. So the hope is that we're going to offer the participants care coordination services from the same providers that they're going to regularly receive care, including psychiatric rehabilitation, mobile treatment, and opioid treatment programs. This is a quote from Maryland. Again, where does the consumer-driven programs, where are the self-help programs, the recovery programs that are a very effective and important component, particularly around substance abuse and increasingly around mental health issues? The accessing the services. Ron talked about using effective services and monitoring the quality of these services. Well, unfortunately, of the 33 quality measures that are going to be used to hold the ACOs accountable for meeting the minimum quality standards, only one, screening for depression, is related to behavioral health. So it's not that all the providers are not supposed to, they're supposed to use effective services, they're supposed to use evidence-based services, but again, if you're not monitoring it, it's not likely to change. Depression screening is the only one of the 33 required monitoring components that has something to do with behavioral health. So again, just because something isn't required in the law, it doesn't mean it shouldn't be required locally in some of these organizations. But again, as Ron was talking about, unless we take some actions, it's likely that these things aren't going to be put in place. Then increasing access to services, again, the substance abuse disorder rate in uninsured is much higher than those already involved, even in the low-income Medicaid enrollees, and we know the low-income Medicaid enrollees also have higher rates than the general population. So we're enrolling a population that we already know needs services, not even screening, but how to get them effective services. And then, so some of our national studies, again, trying to look at what's been going on. The Parity's been in place for a while. The National Survey of Drug Use and Health, which is an annual, it's actually continuously in the field, that the federal government sponsors. Bush and his colleagues looked at those persons ages 20 to 64 with income less than 13% of the federal policy level, trying to gear in on those people who are particularly being targeted in the Affordable Care Act. And they found that they had higher rates of substance use, but only 47% of the people who had insurance had received treatment. And if we actually look at treatment from medical specialists, it was only 31% of the people. So getting people enrolled is only 1/3 of the task. And this is with existing services that, again, we're getting more people enrolled with agencies and organizations that traditionally didn't do behavioral health. So we're not necessarily going to even monitor this percentage of the newly enrolled getting services unless we are really careful about it. So we have about 24 million Americans that have substance abuse disorders. And it looks like at any one time from these national surveys, maybe only 10% are receiving treatment for their addiction. So clearly we need to expand the specialty services. We need to expand particularly primary care settings because, again, many people who have these problems have not been identified and therefore they're not in the specialty sector. They're still seeing their primary care providers. And we need to increase the prevention and early detection in the primary care settings. So then we have seen this early impacts of the Affordable Care Act. The home options, many of the states, particularly those states that were not fighting with litigation, the Affordable Care Act, have moved to create these homes, and they probably are all trying to create them now. There's been some additional funding. SAMHSA got $50 million for co-location of grants. There's been 90% federal funding for the first 2 years after creation of the health home services for services that are not traditionally covered, such as health promotion, care management, post-inpatient transition, and information technology. So Ron mentioned that we have had some funds that are being allocated for doing these things, but again, making sure that they're actually being used well. So again, the question, are we really going to improve the outcomes by increasing access? Well, only 10 to 20% of the persons in primary care settings right now are being screened for alcohol problems. This is surveys of current primary care providers finding out what they do with their patients, and they're not currently screening them. Whether the Affordable Care Act, by emphasizing prevention, filters down into your doctor's office, it's not necessarily going to increase their payment. It's not going to necessarily increase the time that they're having to deal with you. Hopefully some of the technology means they may be able to do some of these screenings while you're sitting around waiting to see your physician or using the internet or other things. But again, these are not things that we're likely to see by ourselves. And then less than half of the pediatricians and even a smaller percentage of the family physicians ask adolescents about their use of alcohol. Not screening for whether they meet a threshold of addiction or drinking too much. They don't even ask whether they drink at all. So clearly there's a major training issue around the behavioral health issues that if we think that our primary care providers are going to be effectively implementing what we hope are parts of the Affordable Care Act or which are the underpinnings for the Affordable Care Act, clearly there's not a lot of evidence just that expanding current practices are going to get there. Then about 24 million people. So the main impact of parity has been a decline in the quantity of services delivered. Because if we aren't increasing the number of services being done, and the cost is actually either the same or going up some, and we have more people being enrolled or eligible, then fewer of those people are actually getting the services and the cost has gone up a little bit. Then part of this is who's really available to provide the needed services when lack of health insurance is no longer a barrier to seeking services. Many communities have a real shortage of behavioral health specialists, psychiatrists, behaviorally trained physicians, social workers, psychologists. There's a huge shortage of these individuals, and it's also, at least within psychiatry, not one of the growing areas for training mental health specialists. So I think we have a real disconnect between improving access, at least in terms of reducing the insurance barrier, reducing the barrier conceptually in terms of organizing our services so they're supposed to be doing these things, but both training existing clinicians, but more importantly, increasing the number of these clinicians. Most people who do behavioral health services are not sitting around saying, I wish I had more patients. People are pretty busy. Their caseloads are pretty full. And so now we're bringing a lot more people into the system. Where are the people who are actually going to treat them? And where are the people that are going to treat them with effective practices? So there's a growing concern about the new psychiatric hospital. Here's our old psychiatric hospital. Nobody wants to go back there. But there's increasingly discussions about how jails have become our new psychiatric hospitals, particularly in urban areas, that a large number of people who are residing in jails and increasingly in prisons are persons with significant behavioral health problems. Now, part of this is because being arrested for drugs is one of the main reasons why people get arrested in many urban areas, so they're coming in with that. And many of the people who get arrested with drugs are also arrested for selling drugs. They're also consumers of those drugs. But there's an increasing number of people with serious mental disorders who are going into our jails and our prisons. So persons with psychiatric disorders released from prisons are more likely to return to prison when not provided with psychiatric services upon release. We've had studies that have merged data from health coverage, so we're able to look at who has a psychiatric disorder and is on Medicaid because of their psychiatric disorder, who gets into the prisons, when are they discharged, and we found huge gaps in services upon discharge, because when people go into prisons, their Medicaid coverage tends to lapse because Medicaid is not allowed to provide for the services within the prisons. Some prisons are actually now enrolling persons in their Medicaid because if they need to get hospitalized, they will pay for the hospitalizations because most of the hospitalizations are off the prison grounds, not there. So they're allowed to cover that, but they're not necessarily, this is sort of a small number of places. But we still are not enrolling at discharge. If somebody came in and was in a public, the state which runs both the prisons and runs the Medicaid organizations, and therefore they should have an ability to know that Phil Leaf was getting services and was on Medicaid when he was arrested, convicted, and now he's in the prison. His Medicaid has lapsed, but people shouldn't be released and then told, well, here's where you should go to sign up for your Medicaid. I mean, people should have have these services restored to them, particularly if they were eligible on admission. Their disability probably did not get alleviated by their prison term. That's not one of the things our prisons work on. Prisons, most of them do have some health care professionals there, so they can at least document this person hasn't miraculously recovered and still is disabled because of their criteria, and that's one of the things that gets you on the Medicaid is the disability. There also tend to be very low-income persons. So why the Affordable Care Act doesn't have a dedicated terminal in all of our jails and prisons that gets people who say, I don't have coverage now to enroll right then and there, when there also should be somebody who can help them actually work the computer, are things, but these are things that are at least not taking place right now. And so our previous research that shows people recycle because of their substance abuse or mental health problems, and then get reconvicted and go back into prison at much higher rates, and that the lack of their services, as measured by not returning to be on the Medicaid rolls, is one of the things that's very predictive of that. Also, each year we have more than 60,000 youth in America who are placed in juvenile detention facilities, and close to 70,000 reside actually in the correctional facilities on any given day. 65 to 70% of youth in contact with the juvenile justice system have a diagnosable mental disorder. 60% have a mental disorder, also have a substance abuse problem. Almost 30% of our youth with these disorders, they're serious enough to require immediate and significant treatment. These are youth, again, who need behavioral health services. Many of them aren't getting behavioral services while they're in the juvenile justice system. Juvenile justice systems, most of those youth come home, and most of the youth come home pretty quickly. We're talking about months, if not within 18 months. for the vast majority of those. Again, an opportunity under the Affordable Care Act to try to make sure they are enrolled. And if they are enrolled, what is the appropriate system? Again, hopefully the juvenile justice system, more than the adult correctional system, really is there to support youth, to try to get them the services and the supports they need so they don't have to graduate into the adult correctional system. Well, those who have substance use and other behavioral problems or mental health problems clearly have some significant needs, and it's incumbent on that silo within most of our states and our health silos and our community silos to get together somehow so these youth who are identified, their problems are often well categorized because they are at least getting assessments, if not services, upon discharge really need to get these behavioral health services, and it will be important to look at those things. So unfortunately, this little cartoon gets to be used way too much. So we have our community-wide strategies that we spend all of our time sort of coming up with. And then we have some consensus, potentially good consensus, about what we want to achieve. But the middle tends to be some sort of miracle. And so really needs a little bit more work right up there with the miracle part. And unfortunately, one of our strategies is to connect the dots. Somehow, if we had just people and programs co-located, working together, that's part of the solution. Unfortunately, when we look at these individual services, they tend to not have very good outcomes. Most of them are, in the behavioral health, are not using evidence-based practices. Many of them are not very consumer friendly. So why we think simply connecting the dots is going to produce us a better outcome than simply we have already, or disconnected, I think is an important question. And again, it's an analogy I frequently use. I think we mostly we all talk about the need to connect dots, but again, I'm not sure that's the strategy. And now those of you with squeamish stomachs can turn away from your screen. Unfortunately, we got to make sausage. And we got to make a pretty big sausage, because we have a large number of persons with behavioral health problems in the U.S. Many of them are already, quote, in services, insured, not getting effective practices, not getting services, not getting the supports and the recovery programs that they need. And even more of them need to get enrolled, and the Affordable Care Act provides us with an opportunity. But I think we're really far away from figuring out what that sausage should look like in each of our communities, and it's likely to be multiple sausages in the community. It's not going to necessarily be a one-size-fits-all, but unfortunately, I think it's a lot more than simply connecting the dots. So we're really talking about paradigm shifts. We're not just system integrating in both systems and services, but what does that really mean? How, it's not just integrating, but it's creating new things. Who's guiding this process? Increasingly, the process is getting guided by people that we affectionately call bean counters. It's been moved away from persons, particularly in behavioral health, who have the substantive experiences for organizing these services into potentially Medicare or Medicaid programs or health insurance programs. Where are the persons who have the expertise on the kind of services that are effective with persons' behavioral programs, and are they 6 or 7 levels down in the decision-making process? Systems of what? I'm not sure we know. And again, unfortunately, don't go to your favorite academic, because I'm not sure she or he knows. We really don't have a lot of good models. Even our best models have a lot of persons with behavioral health needs that are not being adequately served. So we really do need to move, as Ron talked about, from treatment to recovery and wellness. And most of our healthcare providers, and unfortunately even most of us in public health, we're really big on looking at problems and needs and a little bit on treatment, not much into wellness, and almost nothing on recovery and sustaining recovery. So I think this is a really important area for our public health practitioners to be focusing on, working on how do we really promote recovery and wellness, and where are the aspects of behavioral health that are impeding that in your local communities. It needs to be whole population, and increasingly, as in all of our things, we have much more consumer involvement than we had 5, 10, 15 years ago. We have consumer groups, we have survivor groups, we have persons working with family members of persons with dementia, elderly. How are we going to be including those persons with behavioral health problems, or supporters of persons with behavioral health problems, in our discussions? Because none of this is really working very well in most of our communities. And again, there's nothing to think that the Affordable Care Act will magically change that. So we're going to end there and I guess go to some contacts. The materials that you get will have some contact information for us. And we also included some resources. I think he's on.
Okay, thank you very much to both of our speakers. And it's time for our Q&A, and I just ask that people online feel free to send in questions. Just click on the link or go to maphtc@jhsph.edu. For people in the audience, if the live audience, we don't have someone today to bring the microphone to you, but there's a microphone on each side. Somehow everybody is sitting on one side. And you just push the switch up from red to green. So I'll start with people in the live audience. Any questions to get us started for either Ron or Phil? Okay, you can take some time. We do have some questions online. One is about the issue of primary care screening. And the question really is, you spoke about, Dr. Leaf, about training and the lack of training of primary care practitioners. But the question is sort of organization of the visit, so to speak, and the time for screening, and then appropriate referral, and how mental health advocates can impact that.
I also might have a comment. So I actually was in Australia last month, and Australia is very much further ahead of electronic measurement and monitoring and using the internet. And they do a lot of screening, and this was a meeting that had a lot of consumers in it, and they were in some ways very positive about using some of these instruments just in the waiting rooms or when people are moving into a new program, getting assessed. It was a program of youth and young people who are much more than I, very facile with internet and communication and Facebook. So they weren't at all off-put about getting these things as part of their overall assessment when they moved to a new clinician or when they were having some problems. And so I think, again, one of the partial solutions is the increase in technology, which will make some of these screenings more accessible to be used in a variety of settings, and then it's up to the training for being able to use the information effectively, because again, as screens, they're not diagnostic tools. That means there will be many people who get identified who may not need additional services, but that I think the movement towards the electronic and the technology will be one of the important things, and there's an increasing number actually of apps where people who are in services actually are able to report back on their feelings using their phone, so they're able to monitor changes in their circumstances. And this has been being used a lot with adolescents and the concern for some of the medications and side effects, to be able to have people sort of just report periodically how are they doing with some very quick questions, and then if the questions aren't responded to at all, or the right answer comes in, then somebody from the office starts trying to contact the person in person.
Ron, would you like to add anything to that?
Okay, a couple of quick things here. There are tools available for screening. The Physician Health Questionnaire, the SF, the SBIRT that I mentioned, Screening, Brief Intervention, Referral to Treatment, all of those are out there and are being used, and we ought to look at how effective they are in identifying people with these issues and how many false positives and false negatives they create. I agree with Phil on the use of IT. We dramatically underuse IT in behavioral health care. And that can range all the way from apps for people with substance use conditions so they avoid potential problems areas. For example, someone who has alcohol issues, avoiding a bar, all the way up to online therapy that has been proven just as effective as in-person therapy. And I guess the third point here would be it's very important that we in behavioral health work closely with primary care to increase the training of primary care providers in the behavioral health area. I just had the occasion to review a paper 2 days ago, and it was on this very topic, and the point of the paper, one of the points of the paper, was that primary care people want to receive such training going forward here. So again, a huge agenda for us.
Okay. There's another question from online. This is for you, Ron, about the electronic medical record.
Yeah.
And the question is if you could speak a little bit about confidentiality and how, especially the sensitivity of that issue for behavioral health issues, and also a little more about what the personal health record is.
Okay, yes, thank you. So a couple of introductory comments here. So I guess the major introductory comment around behavioral health clients and electronic health records is we have very different requirements for people with mental health and substance use conditions. HIPAA, the Health Insurance Portability and Accountability Act, provides assurances of confidentiality of therapist notes under the HIPAA rules, basically, for people with mental health conditions. By federal law and federal regulation 42 CFR Part 2 prevents the sharing of records of substance use clients when they're seen by a substance use professional. So I think there's considerable work needed to work through these issues with the goal of being able to share information electronically, but yet to have assurance that the confidentiality and privacy of that information will be protected. So there's a huge agenda of work in this particular area. I guess one other point I want to raise here, there are brand new guidelines from the Office of Civil Rights on the sharing of mental health information, and I can get you a link and you can share that with the people who are in your audience and online so that they can see these new regulations and how they're playing out here. That's one comment. I guess your second comment, what is a personal health record? An electronic medical record, in effect, is an electronic tool used to maintain all of the data on a client. It may be tests of various kinds, it may be blood pressure, it may be blood sugar levels, it may be various kinds of therapies and how they're working or not working around behavioral health issues and so on, but it's intended to be all-encompassing. In addition to that, what I talked about was the personal health record, which is a derivative out of that electronic medical record that takes the data from the electronic medical record and translates it into information that's useful to a consumer. For example, if I am a consumer that has high blood pressure, I will want to know the trajectory of my blood pressure over time. I will want to know whether the meds I'm taking are working. I will want to know what I need to do to improve my lifestyle to help control my blood pressure and so on. All of those things can be part of a personal health record. And I think a second important point of a personal health record, and very important, is the personal health record should belong to the consumer. It doesn't belong to the provider. It doesn't belong to the insurer. It doesn't belong to the government. It belongs to the consumer. And we're going to see a lot more development in that area as well, I think, going forward here. Third comment, and it's a political comment, when the ARA, the American Recovery and Reinvestment Act, was passed, considerable money was set aside through grants to support the implementation of electronic medical records in health settings. When that legislation was passed, behavioral health care was left out. Since that time, for the last 5 years, we have been attempting to generate a piece of legislation that would extend these grants to behavioral health providers so they can implement electronic medical records. We now have a bill introduced in both the House and Senate. It's not controversial between Republicans and Democrats, and we have high hopes that that bill will be passed this year to put about $1.5 billion into the implementation of electronic medical records for behavioral health care.
Did you want to add anything, Bill? Okay. If anyone in the live audience has a question, you can just raise your hand and I'll recognize you. Okay, there's another question online. which is which type of additional mental health providers are needed, and what, if anything, is being done to create, train, recruit these providers. And I guess this is for both of you. Phil, do you want to start?
Well, there may be some geographic areas that have more mental health or behavioral health providers than others, but I think the data suggests there's a shortage across all of them. And there's also, with the exception of radiologists who only work in hospitals, it's the most maldistributed health specialty that exists. And so we have large swaths of rural and suburban communities that don't have any child or adolescent trained mental health specialists. Increasing communities, there's concern about having geriatricians and people as we get increasing number of older people. So I think that there aren't any mental health specialists or specialties that are seen currently as being oversubscribed. I don't know whether Ron has any other comments.
Ron?
Okay, let me add a few things to that. So I think I agree with everything that Phil has said and would add a couple of following things. It's very important that we use peers more effectively in our delivery system. What I mean by a peer is, I mean someone who themselves has had a behavioral health condition, but who also now is helping other people negotiate care. They're helping to support people. They're serving as care coordinators. They're serving as case managers and so on. We have a huge potential workforce here that we need to get engaged in the implementation of care under the Affordable Care Act. And that will be not only peers helping people with behavioral health conditions, will also be peers helping people who don't have behavioral health conditions in the integrated health homes that we both talked about. Very important. Secondly, second part of your question, well, what is going on about this? So there are some new things, and there are some old things. There actually is an old strategic plan on the SAMHSA website that was developed by 2005, which was the Strategic Plan for Human Resources in Behavioral Health Care. Even though it's somewhat out of date right now, it's worth reading because I think a lot of the things it talked about are still true. Going forward here, I know and was just at a presentation a couple days ago at SAMHSA that SAMHSA is adding human resources as a major focal initiative area for the years 2014 to 2018. Secondly, there's a much better working relationship between SAMHSA and HRSA, the Health Resources and Services Administration, around the HRSA training program. For example, HRSA operates what's called the National Health Service Corps. National Health Service Corps trains about 13,000 providers a year. 3,800 of those 13,000 providers are behavioral health providers, psychiatrists, psychologists, and social workers. And also, I think going forward, we're going to have to, third point, work with the discipline. I'll give you one example here. I know from having watched the data for a very long time that psychiatrists in the U.S. are aging. About 15 years ago, the average age of a psychiatrist was about 50. Now it's 57 and a half. A psychiatrist who's 57 and a half right now was trained in the Vietnam era. That person is going to retire in the next 10 years. So we've got a cohort of psychiatrists that is gradually aging out, yet we haven't done the work we need to do to think through the replacement of that discipline, et cetera, et cetera. So huge area, needs a huge amount of work, and the Affordable Care Act is going to bring out many of these issues.
Okay, if you want to grab the microphone, you can pull it out and just, you have to push to green so Ron can hear and people online can hear.
Thank you so much. You mentioned that enrollment is only a third of the work. How do you envision the role of community health workers in getting people involved?
That's a great question.
Bill, can you repeat the question? I couldn't hear a single thing.
So the question was how might community health workers get involved, particularly as they relate to behavioral health issues?
Yeah, okay.
And so, as some people may know, CMS had over $2 billion of funding for innovative programs that would reduce rehospitalization. And a number of them really focus on this issue of the community health worker. And some of them focused on it as it related to persons with behavioral health problems. But increasingly, hospitals and even primary care providers who were used to be just concerned about the services they were concerned about are concerned about wellness and recovery. And so in lots of places across the country, community health workers are getting trained and incorporated into the healthcare delivery systems to both be able to identify persons out there and get them into the services. And so they're being used right now to get people enrolled. But also because there's a lot of comorbidity between behavioral health problems and health problems. So many people who go in for cancer treatment, for diabetes, for other kind of things, a big indicator of them not likely to do well or to do less well is do they have a comorbid behavioral health, substance abuse, mental health problem, which used to not get treated all that well because they'd be on a unit that didn't have mental health specialists. So I think there's a growing concern, and that one of the issues from the public health establishment is how do we identify these community people? How do we engage some of the persons who are in recovery for behavioral health issues to make sure that they are also included in the cadres of community health workers? And how do we also make sure that they're not siloed, so we have the persons dealing with behavioral health issues and their community health workers, and people dealing with physical health issues and their community health workers, because a very large percentage of the unnecessary rehospitalizations have been found to be due to persons with some sort of behavioral health problem in addition to whatever the physical health problem. So I think, again, that's something that's really promising, in that there's a lot of activity now. How to keep track of that activity? How do people who are working in local communities and trying to develop these programs get expedited access to this is actually one of the things that Ron and I were talking about, because it's not just the community health workers. There's a lot of stuff getting invented at the moment, or sort of fine-tuned at the moment. And unfortunately, we don't have a lot of infrastructure for that information around behavioral health issues, whether it's with the community caseworkers or anything, to get down to the consumers and the local communities who are trying to develop these programs now. So that how to do that is a real gap, but the recognition that community health workers will be playing an increasingly important role in our new healthcare system is something I think is getting widely accepted.
Okay. In the audience?
So you mentioned that no studies found increased utilization of mental health service after parity legislation, and this suggests it's important to not only to increase affordability of care, but also reduce some other barriers for seeking help. And I think those with mental health disorders are not willing to seek help because of the stigma or some other things. So what do you think is important to reduce such barriers other than financial affordability?
Okay. So I'll say something, but I also know this is something Ron's been very passionate about. So clearly there's a lot of stigma about behavioral health, and it's both within the professionals of not wanting to deal with it or not feeling comfortable dealing with it, but also the persons themselves and also their families and the community. So one of the things we need to be doing, and again, this is one of the things that community health workers are particularly adept at doing because they are from the community, is trying to reduce the stigma, to trying to let people know that we're moving from an illness model to a wellness model, and that part of what you'll be doing and the participation is not just not having your disorder, but it's dealing then with the consequences of having it for a long time that may have dealt with, for example, an arrest record if you were using substance abuse. So you may be clean and sober, but you can't get a job now because it's harder because you have an arrest record or other things. So I think, again, that the stigma is we've made some progress, but I think we haven't made enough, and it's clearly an area where the consumers themselves play a very important role of leading that at the local community and becoming the headlights rather than, as a friend of mine talks about, the taillights for some of these efforts. Ron, I know you've also been working a lot on the stigma issue.
A couple of things to add here. I would point out to the person asking the question that there's a special issue of the American Journal of Public Health that we did last year that talks to this issue. It talks to the problem of stigma in behavioral health. It talks to things that are being done to address the problem of stigma and so on. And Phil talked to various ways of addressing that. We think that full community integration is an important antidote to stigma, that even if we build integrated delivery systems of the type we're talking about today, health homes and medical care homes and so on, unless we can achieve full community integration where behavioral health consumers are your neighbors, they live next door, they work next to you, they're in the university with you, we can't completely overcome this. And I think that realization has led to a lot of new developments. Final comment here. There are brand new guidelines from the U.S. Department of Health and Human Services on the delivery of integrated care, the integration of housing, and the integration of work for these populations that I think will be very effective and helpful here.
Okay, I can't believe it, but we're 2 minutes shy of being out of time. So I just want to take this time to thank people in the live audience and the online audience and remind you that probably by tomorrow, the PowerPoint presentations and the link that Dr. Manderscheid mentioned will be posted on our website. And in about 2 weeks, an archive of the presentations will also be posted on our website. And I really want to thank both Dr. Manderscheid and Dr. Leaf. This has been a really stimulating and important discussion and presentation. And Dr. Manderscheid suggested that we have him back, and Dr. Leaf too, to talk about prevention of mental health or behavioral health disorders. And that's a whole, another very worthwhile topic that we will try to present again in the future. And I just want to remind everybody, our next Grand Rounds is on April 2nd. And you'll be receiving information about it via our regular email. So thank you very much. Have a good afternoon. Bye-bye.
Thank you.
Thank you.